All right. This is a discussion on different valvular disorders. I'm going to be reading and talking as I go, and hopefully I can stay on track. So first of all, the basic idea here of valvular disorders, it's also heart sounds, things like that. This is a mechanical representation of a person's heart. This is the right atrium, this is the right ventricle, this is the left atrium, and this is the left ventricle. Okay? Right here is a little valve. Right here is a little valve. Blood goes out of the heart like this, out of the heart like that. This here goes to the lungs. This here goes to the body through the aorta. There's a little valve here. There's a little valve here. Blood comes in through the top here into the right atrium from the body. Blood comes in here from the lungs. Okay, so if you follow the basic diagram here, blood comes in, deoxygenated from the body through the superior vena cava, inferior vena cava, into the right atrium. Then it is pumped from the right atrium through this tricuspid valve, tricuspid valve into the right ventricle, and then it is squeezed during systole through, systole means like when the ventricles are contracting, it is squeezed during systole through this pulmonary valve into the lungs. The blood becomes oxygenated in the lungs, and it goes from the lungs through here, there's no valve here, into the left atrium. During diastole, it fills up. During diastole towards the end, it starts to squeeze down, pushing the blood in here. When the blood gets full enough in here, diastole ends, systole begins, this squeezes down. As soon as systole begins, this valve closes. This is called the mitral valve. This mitral valve closes, and when this is squeezed down enough, this valve right here, called the aortic valve, opens, and blood is pushed into the body. There are generally, as far as I know, two major problems with these valves in general. It's called regurgitation, and it's called stenosis. Okay? Sometimes you can also have prolapse. I'll explain that in a minute. So you can have regurgitation, and stenosis. Regurgitation or stenosis can happen at this valve, this valve, this valve, and this valve. Any one of them can have regurgitation or stenosis. Stenosis is when the valve doesn't open up all the way. Normally, when your valves are working, they open up all the way, all the blood goes out, and then it closes. But in the case of stenosis, it tries to go out, but it doesn't open up all the way. So what happens when you put your finger on the end of the garden hose? The water, that'd be creepy, the water squeezes out really fast out of the garden hose, and it makes a kind of a spraying kind of sound. Well, that's pretty much exactly what's occurring in the case of stenosis. You could have stenosis of any one of these. The most pressure is coming off of the left ventricle. This is the one that really has to squeeze hard because it's pushing blood into the body, and that's the place of the most resistance. And so the left ventricle has to be very strong. And so if this aortic valve becomes stenosed, it really has to push hard past this. Anyway, yeah, mitral can be stenosed too, whatever. All these things. Typically, when a valve becomes stenosed, the concept here is that now this ventricle is trying to push a lot of blood through a little tiny space. And that's a lot harder than pushing a lot of blood through a big space. So in order to compensate for having to squeeze a lot of blood through a tiny space, this left ventricle is going to have to get stronger and thicker and bigger. Okay, that's called hypertrophy. So sometimes you'll find that in the case of stenosis, that the heart chamber that's pushing through that area becomes hypertrophied or bigger, okay? Same thing can occur here. If you have mitral stenosis and the left atrium has to push all the blood through this little tiny space, this will get bigger frequently. So what about regurgitation? Okay, so normally a valve, when the heart squeezes down, the valve is supposed to open up, and then when it's not squeezed down, the valve is supposed to close. Now in the case of regurgitation, it doesn't close properly. Remember the other one, stenosis, was it didn't open properly, didn't open all the way. This one doesn't close all the way. So if the valve can't close all the way, what happens is it goes to close, and look, there's blood that can leak back. And so while it's squeezing, blood is also going back. So by an example, so let's say right here you have mitral regurgitation. Okay, so the blood is, when this clamps down, all the blood's supposed to go out this way through the aorta. But while it's squeezing down, this has a hole in it. It didn't close properly. So some of the blood gets pushed back up in here. Well, that's going to increase the pressure in here. And if there's increased pressure here, that means that the left atrium is going to have to try to compensate for that because it's going to have more blood, which is more pressure, which means it has to do more work. So it's going to get hypertrophy to compensate for that. Okay, same thing happens here. If this valve, the aortic valve, has regurgitation, then your left ventricle is going to have to push. So explain, when it pushes all the blood out, the blood goes out, it doesn't have a stenotic problem, it all goes out fine, and then it stops squeezing all the way, and it closes, the valve closes, but it doesn't close all the way. And remember, there's a lot of pressure in the aorta, okay? So this is a low pressure area because it's got rid of all its blood, and this is a high pressure area because it's the high pressure aorta and blood's just been squeezed in there. If this valve doesn't close all the way, blood's going to leak back from the aorta back into the left ventricle, and the left ventricle now is going to get all the blood from the left atrium and the lungs, everything going here, as well as some additional blood leaking back from the aorta through this regurgitant valve. And so this ventricle is going to have more blood. And if it has more blood, it's going to have more pressure. And if it has more pressure, it's going to have to compensate for having more pressure by getting stronger. And if it does that, it's going to undergo hypertrophy. And so you can see how this concept works, hopefully. Okay, so let's talk about a physical examination. So a patient comes in for physical examination, and you're going to have to diagnose these different heart sounds. Okay, they're going to sound. Each one's going to sound a little different. It's going to be a different place. So first of all, take your stethoscope and you put it on different places to hear different valves. And there's a little acronym they use for this. Okay, so right down here, about on that spot, you listen, and it's on the right of the sternum, up high. So right intercostal space next to the sternum. You listen, and that right there is where the aorta. So the aorta kind of goes like this. This is where you'll hear the aortic valve. I know it's down here on this illustration I did, but this was a mechanical. This is not anatomical. In reality, it looks like this. This isn't exactly what it looks like. This is going to be kind of the best of my memory. Got other weird things going on here. Anyway, so right there though, this in reality squeezes up like this. This is the left ventricle here, and then the right. Anyway, it's all messed around. So right there, up, which is right there, okay, on my right side, is going to be where you listen or auscultate for the the aortic valve. And they made this silly acronym, and it goes, all physicians take money. Aortic for all, pulmonic for physicians, P for physicians, T for tricuspid for take, and money, mitral. All physicians take money. And so you listen on those different places if you want to listen to those different valves. And so if I want to listen for aortic stenosis, am I going to listen down here where the aorta is not? No, I'm going to listen up here on the aortic valve for stenosis or regurgitation for the aortic valve. If I want to listen to pulmonic valve, see if it has aortic regurgitation or stenosis, I'm going to listen over here on the other side, just across, to listen to the pulmonic valve. If I want to listen to the tricuspid, I'm going to listen down here next to my sternum on the left side. I don't remember the exact intercostal space. And if I want to listen to the mitral, I'm going to listen down here, down by the apex of the heart. Apparently that's further down there. So that's how you listen to these. So one note here is that yes, you can pick up stenosis or regurgitation through auscultation of the heart. These valves, especially if it's caused by stenosis, apparently, the valve area is going to be totally asymptomatic. You're not going to hear anything, whatever, until the valve area is greater than 1.75 centimeters squared. Somewhere between there and 2 centimeters squared. So somewhere between 1.75 to 2 centimeters squared, you're not going to hear anything. It's going to be asymptomatic because of stenosis. Okay? So when the patient comes in, you're not going to hear anything until it gets that. Now, what about when it gets that? It's like more than 1.75 to 2 centimeters. Then you're going to start having some symptoms. They're going to come in and they're going to complain of some things. One of the things they're going to complain of is dyspnea. Dyspnea means shortness of breath on exertion. So, in other words, when they go exercise, they're short of breath. Another one, orthopnea. Now, I need to double check. I believe orthopnea has to do with the position that they're in. But however, I'm going to double check that because all of a sudden I'm doubting myself. Happens sometimes. I believe it has to do with the position that they're in. Makes it worse. So it says orthopnea is shortness of breath which occurs when lying flat. Okay, that's why I was right. So basically, what it means is they lay down flat and they get short of breath every time they lay down flat. Well, that's extremely discouraging to sleep. So the person says, "Doctor, every time I lay down, I feel like I can't get enough, breath." So that's another symptom. Next one is paroxysmal nocturnal dyspnea, which means that at night, when they're laying down parallel and they're trying to sleep, they are short of breath. And again, I'm going to double check on the definition of that. Paroxysmal nocturnal dyspnea, just to make sure that I'm saying correct. So this is a case refers to attacks of severe shortness of breath and coughing that generally occurs at night. Okay, so I have the right idea. So typically there is a progression associated. The particular lecture that I'm looking at right here as I'm talking about this is on mitral valve disorders. So typically the progression of this is going to have right ventricular failure, which means in the case of this particular disorder, mitral valve disorder, if I'm understanding this correctly from this person's handout, first it's going to be right ventricular failure, and the person's going to get ascites, which is like basically gets backed up into the liver, if I'm remembering correctly. Then they're going to get peripheral edema, and then they're going to get hemoptysis. Okay, so let's talk about why this might make sense. So first of all, if this is mitral valve disorders, mitral valves right here, didn't really specify whether it's regurgitation or stenosis, but either way, what is it that comes back from here? It's going to be, this goes back to the lungs. So let me double check on ascites. I don't want to say anything incorrect in this video. I've done those in the past. I don't like to do that. So the accumulation of fluid in the peritoneal cavity causing abdominal swelling. Okay, so you have it. So they get swelling. They get some fluid accumulated in their peritoneal cavity, and that's it, ascites. Okay, so it gets up in here. First thing they're going to have, though, is right ventricular failure. Maybe it's in the case of right ventricular failure. Then they get the peripheral edema. That means that out here on their arms and their legs and the periphery, they get their hands and ankles and stuff get swollen. And then hemoptysis is where they are coughing up blood. Hemo means blood, and the other one's coughing. It's coughing up blood. Next is the enlarged left atria can impinge on left recurrent laryngeal nerve, causing hoarseness or impinge on esophagus. So remember I talked about earlier about how the atria of the ventricles have to compensate for the fact that they're having to push through or maybe they're getting refilled with more fluid. Basically, what this is saying is that over here on the left atria, there is a nerve. It's called the laryngeal nerve. And it passes down like this. And this laryngeal nerve, if this left atria gets too big, it moves over and actually impinges on it. It pushes on it. And this laryngeal nerve is responsible for your esophagus, okay, or also for speaking. So you might hear the person's voice will get hoarse, or it might even push on their esophagus. Sorry, I said that wrong the first time. So that can happen sometimes. So those are some symptoms. The person comes in, they've got some hoarseness. You know, you see maybe they've got some ascites fluid in their peritoneal cavity. Maybe they've got right ventricular heart failure. Maybe they have dyspnea. Maybe they have paroxysmal nocturnal dyspnea. Maybe they have orthopnea. Any of those sort of symptoms that come in, you want to start thinking, maybe this person has some kind of stenosis or regurgitation occurring here. So you're going to perform a physical exam. And you got to notice here, or worthy mention, is that if it's mitral valve disorder, that the murmur is very subtle and can very easily be missed completely. Like you might listen to it, I hear normally, but it's because the sound be very subtle, it'll pick it up. So, however, it says that the closer the opening snap is to S2, the worse the mitral stenosis. So let me pull up something really quickly so that I can, clearly explain how this works. So basically, the way that this works is you have these different heart sounds, and these different heart sounds will correlate to diastole and systole, and to different events in the heart. So pulling them together really quickly here, we have the first heart sound is going to occur when the AV valve closes, atrioventricular valve. Okay, so these are atrioventricular valves up here, AV, because they're between the atria and the ventricles. So when the AV valve closes, that is where you're going to hear the first heart sound. Okay, so AV valves close, makes a little sound apparently associated with that. That's your first sound. Now, when the second sound occurs, this is going to be when the AV valve opens. Okay, so the atrioventricular valve closing is your first sound, and then it opening again is your second sound. And sometimes you'll get a little bit of a third sound, a little bit, kind of during the filling stage, and that's basically when the blood starts filling in here, it kind of bounces around there sometimes. Sometimes you can kind of hear a little bit of a third sound, but that's not typically something that you hear that often. And there actually can be even a fourth sound. I think that's with aortic stenosis, and that's kind of a different situation altogether. So AV valve closing is your first sound. AV valve opening is your second valve. Let's talk through this really quickly. So why does your AV valve close in the first place? So your AV valve closes when your ventricles contract. Okay? So when this starts to contract, these little flaps here, they're kind of like little parachutes almost. And when they push this way, they just kind of let the blood flow. And when it comes out, they go kind of like that. And that's how they close, like little pocket kind of thingy. So when this thing starts to clamp down really hard, so back up a little. When the blood was flowing through here, it was open because it was going. And then when this guy clamps down to push the blood through there, that sends some pressure here. And this guy catches up just like a parachute and goes, and that, during the beginning of systole, when this guy contracts, is the first heart sound. Okay? And then so that's the first heart sound during systole, when the left ventricle and right ventricle are contracting. And then once the left ventricle and right ventricle have let out all their blood and they're empty, Now the pressure up here is greater than the pressure down here. So what's going to happen? Well, this valve here is going to close for one as soon as this guy's done squeezing, because all the blood's gone through there, and then all the blood's out. No blood, no pressure. So now it starts to go back, and then this valve goes, and this valve suddenly opens because there's no pressure down here, and this one went this way. So now the blood starts pouring in. Okay, so repeating again, first sound is when this guy starts contracting, closes this AV valve, these out valves here. Okay, squeezes out of the blood, squeezes out of the blood. Then second heart sound is right when this squeezes out the last bit of its blood, and it starts to relax, and then blood starts to go back, and it closes this valve. And now that this is relaxed, the blood from here now is greater than this blood, so this one's squeezing down. And so the second heart sound is going to be right when this one opens and this one closes. Okay, so that's kind of a way of keeping track of that. And yeah, I think it covers the heart sounds pretty well. So let's go back to where we were talking about other things on physical exam stuff. So typically, the closer the opening snap is to the S2, the worse the mitral stenosis. So we have this little opening snap when this thing just opens up originally, a mitral stenosis. So remember, opening was the second heart sound, so that's the S2. So the closer the opening snap is to the second heart sound, the worse the mitral stenosis. I'm trying to think of a good reason why that would be. I can't think of one off the top of my head, so sorry. Okay, so when the mitral stenosis worsens, the murmur will last longer. Let's think about why that is. That's pretty straightforward, okay? So if I were to try to blow water through a garden hose from here to over there, if I've got a little piece of garden hose, is the water going to go faster if I use a garden hose or if I use a straw? Am I going to get all the water in my mouth out faster? Well, obviously it's going to go faster if I use a garden hose because it's got a bigger hole. A straw has a tiny little hole. So it's the same way with this. I'm trying to get all the blood through here. Is it going to go from here to here faster if this valve is tiny and squeezed off? Or is the blood going to go faster from here to here if this is a big valve? Obviously, it's going to take longer if it's a tiny valve. So mitral stenosis is basically like having a tiny valve. And so the sound of shh is going to last longer in the instance of mitral stenosis. Okay, so the question is we need to figure out certain maneuvers that a person takes that are going to increase the heart sounds or decrease the heart sounds. Okay, so it says to apply the appropriate physical maneuvers in assessing and distinguishing mitral heart murmurs. So first of all, we have our diastolic murmur. So let's think about what will be happening during diastole. So diastole is when the ventricle is relaxed. When the ventricle is relaxed, blood is flowing from here down into here. Okay, this is diastole. So stenosis is going to slow the blood from flowing from here. So mitral stenosis will be your diastolic murmur that's going to occur there. If it's mitral regurgitation, then what's going to happen is this thing isn't going to make any abnormal sounds until it tries to close. Okay, that means when the ventricles during systole, when the ventricle contracts. So during systole, the ventricle contracts, the blood is stopped by this valve, except for we have regurgitation, so the valve doesn't close all the way, and so some blood actually squirts back up into the left atrium, and you hear a sound during systole. Makes pretty good sense. So, apparently, during the diastolic murmur, the sound will increase with amyl nitrate or with squatting. So what does amyl nitrate do? Amyl nitrate, however you say that, AMYL nitrate, that's going to cause vasodilation of your vasculature. It's going to start with your veins, and then later it'll do your arteries as well. So that decreases the preload, amount of blood coming into the heart. It also ends up decreasing the afterload, so it decreases the amount of pressure pushing out on the heart as well. So there's less pressure out here on the aorta because all the vasculature is expanded and it's easier to push blood into a big space than it is to push blood into a small space. So taking some nitrate, why would that make the murmur louder? I'm not exactly sure why it would make the murmur louder. That's what the study guide says. I'm trying to think of a good reason why. And I'm not really sure why it would, but that's what it says. So just be aware that if you take nitrate, amyl nitrate, and the person has a diastolic murmur, that the murmur is going to be louder for an unknown reason. Also, squatting down is going to make it louder. And this one actually does make sense. So when a person squats down, essentially what they're doing is they're putting pressure kind of on their periphery and on everything in their body, which is putting more pressure on their heart, which is going to decrease the amount of blood going out this way and probably increase blood coming into the heart as well. So you can kind of reason through that, I guess. Just be aware that's kind of what squatting does. And that's going to have an effect on your mitral valve. And I guess it makes the murmur and mitral stenosis, the diastolic murmur, that's mitral stenosis, diastolic murmur. It's going to make it louder. So, however, it's going to decrease in the instance of doing the Valsalva maneuver. So the Valsalva maneuver is a maneuver that people do usually to kind of slow their heart down. Because sometimes your heart is going to kind of go into this sympathetic crazy thing that's going to be really fast, and you can kind of trick your baroreceptors. They're like BARO receptors. You've got these receptors in your body that kind of track the blood pressure, and if the blood pressure gets too high, they send a hey, calm down, kind of a parasympathetic signal telling your heart to calm down. So the way you do this is you hold your breath, and you kind of bear down like almost like you're gonna strain to go to the bathroom, okay? But don't actually do that, that'd be messy. So you hold your breath and you bear down, and it kind of tricks your baroreceptors, and your baroreceptors slow down. It's like, whoa, too much pressure, whoa, And so you get this kind of parasympathetic signal, it slows things down. And it would make sense that during a diastolic murmur, remember during diastoles when the blood's flowing through here, that's going to make that, if you perform that maneuver and slow the heart down, that this sound's going to be quieter. Okay, so it decreases the murmur. Okay, there's also something called a Graham-Steele murmur. And let's talk about it looks like Graham, like Graham, like graham cracker. It's a Graham-Steele, Steell murmur. This is an early diastolic murmur heard along the left border of the sternum. So if it occurs early in diastole, so you remember diastole is when the ventricle is relaxed, so blood is flowing through here. So it's going to happen early on, and it's going to be along this left sternal border, which makes sense because that's where this part of the heart would be. So you hear it over there, and it happens early on in diastole. So it says it's due to dilation or distortion of the pulmonary valve ring that occurs in patients with mitral stenosis. Which totally makes sense. So you've got mitral stenosis, which is the time you would hear it during diastole because the blood's flowing through here. So, however, in this case, it says a distortion of the pulmonary valve ring. So it must be guessing up there. I'm not really sure exactly where it is. But, okay, the pulmonary valve, that's down here. What am I thinking? That's down here. So it says a distortion of the pulmonary valve ring that occurs in patients with mitral stenosis. So the person has mitral stenosis, and you make the connection. So it is due to high pulmonary venous pressure. So pulmonary is lungs, so the veins in the lungs have a lot of pressure on them. So as they're if it goes away from the heart, then it's an artery. If it comes back to the heart, it's a vein. So here's the pulmonary vein coming in here, and there's a lot of pressure in here, and all that pressure is trying to come this way, and it's trying to get through this little space during diastole, and it's going to make some sound. Okay? So it says there's typically also right heart failure. So over here's the right heart, and the right heart is what pumps the blood into the lungs. So if this failed, then it's not going to do a very good job pumping blood into and through the lungs. So it's typically associated with right heart failure as well. So the major causes of mitral valve diseases are going to be as follows. Number one is going to be something called rheumatic fever. So rheumatic fever is an instance where a person, usually a young person, gets infected with streptococcal pharyngitis. And this streptococcal pharyngitis, in the United States, we give people antibiotics when they have this. They go in, they get a rapid strep test. We know within minutes whether or not they had, whether or not it's strep throat. If it's strep throat, we give them cephalexin, cured, no problem. However, if it isn't in a place where they have access to cephalexin, the person doesn't take cephalexin, a person can get a sore throat with streptococcus for a long time. And if this streptococcal infection lasts for a really long time, your body's going to start forming antibodies to every part of it that it can. And one of the things that it's going to form an antibody to is something called an M protein. And an M protein is a protein that's from the streptococcus that's really, really similar to a protein that our body makes. And that's bad, because now our body is going to start being attacked by our own immune system, because your body is trying to kill the Streptococcus M protein, but it can't distinguish between the M protein that's similar that our body makes, and so it starts attacking our body. And it goes in, and the person gets a fever, and all these things, usually like 2 or more weeks after their strep throat's totally gone. They thought they were all better, and all of a sudden their immune system starts attacking themselves. And what happens is it attacks this mitral valve right here, and it messes that valve up. It can cause regurgitation or stenosis. In this case, we're talking about stenosis. So it basically comes here, it attacks it so much, it makes this valve all scarred. And so it's all scarred and big and nasty, and hardly any blood can flow through here. And the person ends up getting mitral stenosis. So that's the first thing. But that's not the only cause of mitral stenosis. Sometimes when babies are forming in their mother's wombs, things don't form properly. So sometimes a person can get mitral stenosis because of congenital reasons, meaning their valve just didn't form right. Sometimes it also can happen from severe mitral annular calcification. Okay, when people get old, their bodies start to break down, they wear down, they've had all this, maybe they've had inflammation on this for a long time for some reason, and after a while the inflammation kind of can cause some calcification. And this calcification kind of make this sort of rigid and hard, so it doesn't open up all the way. Now, if that happens, the person would have calcification. The other thing that can occur is something called systemic lupus erythematosus of the, it says on here right atrium, doesn't even make any sense. But anyway, that's the other problem that can happen with it too. So it's the person going to get systemic lupus erythematosus. Okay, so next question here is understand the etiology of mitral stenosis. And so we already understand that rheumatic fever is a leading cause. Other causes, I listed some before, but here's some more. It also says core triatriatum. I'm not sure what that is, actually. Mitral annular calcification, systemic lupus erythematosis, we already talked about, rheumatoid arthritis, left atrial myxoma. Let me explain what a left atrial myxoma is really quickly. So this is a type of cancerous tumor. It's benign, however. A myxoma, it's like a giant mole. It's like one of those ball and chain kind of moles. So it doesn't, the mole itself, the myxoma is what they call them, is not going to like spread everywhere and kill your whole body like malignant melanoma does or something like that. What happens is it gets this big bulge here, and it makes it hard for the blood to squeeze through here, and it can cause mitral stenosis because it can obstruct the flow of blood. So that's the left atrial myxoma. Sometimes also infective endocarditis. So if a person, for example, they didn't wash their arm properly when they got stuck, and when they went to go stick themselves, there was some Staphylococcus aureus on the skin there, and they took the needle and they pushed that Staphylococcus aureus into the blood, and the Staphylococcus aureus traveled through the blood until it got to their mitral valve, and once it got to the mitral valve, it infected their mitral valve, and their body tried to attack it by causing inflammation, and this thing got all big and nasty and scarred and yucky, and it can cause mitral stenosis. Also, same thing could happen, I guess, with staph epidermidis. If the person has an indwelling IV catheter, or if they have a valve replacement or something like that. Also, if a person has bovis, I think it's Streptococcus, maybe Staphylococcus bovis, I can't remember, S. bovis, you always think colon cancer. For some reason, there's some weird correlation between S. bovis and colon cancer. If the person has Streptococcus viridans is one that typically happens in your teeth. So if a person already has some damage to their heart, they have these little vegetations of thrombolytic vegetations on their heart, and then they get a dental procedure done. They have to have the vegetations first. So they already have to have some heart damage, and they get the dental procedure done. And some of the bacteria, the viridans in their mouth, goes from their mouth into their blood and travels down, gets down to their heart. Then they can get some endocarditis from that as well, some infection from that. So those are the typical causes. So then it says, understand the pathophysiology of mitral stenosis. So we already explained that pretty well. It says that as the mitral stenosis worsens, right ventricular failure develops. And that makes sense, because if you start here and you make this smaller, this is going to have a harder time. If this has a harder time, what's the next thing? Well, it goes up into the lungs and then goes back to here, and that means this is going to have a harder time. And if this is having a harder time, this is going to get hypertrophied. And if it gets hypertrophied, then it's going to start having increased oxygen demands. And if it has increased oxygen demands, it's more likely for it to not get enough oxygen. And if it doesn't get enough oxygen, then it's going to become ischemic. And if it becomes ischemic, it can start to die. And if it dies, you start getting failure. Okay? So that's what's occurring there. Also, it says, understand what happens to cardiac output. So at rest, when the person doesn't have tons of blood having to go from here to here and into the body and stuff, the person is probably going to be normal. But as soon as they start to, get that heart going, exercising, they're going to start having increased cardiac output. And with increased cardiac output, this is going to push harder and it's going to get noisier and everything. Also, what happens to the pulmonary venous pressure? So pulmonary vein, you always remember, arteries go away from the heart, veins come back to the heart. So the blood that goes from the lungs into the heart, this is actually a vein, okay? So pulmonary veins, what's going to happen is that you're going to get increased pressure due to back pressure from the atria. So this is small, so not much blood can go through here. So this is going to be higher pressure because there's more blood here because it can't get through here. And that's going to push back in here. So this pressure there is going to be higher. Pulmonary arterial pressure. So pulmonary arteriolar pressure, pulmonary arteriolar constriction secondary to left atria and venous pressure. So the pulmonary arterial pressure, so pulmonary artery, that's coming right here. This is blood going away from the heart. It is deoxygenated, so it's a very odd instance where you actually have an artery that's full of deoxygenated blood. Only place in the body that I know of where this occurs. Except for, I guess, when the baby's inside the mother anyway. So what happens is you get pulmonary arteriolar constriction. And so this gets constricted, and that's secondary to left atrium and venous pressure. So this gets really high, and I guess that back gets constricted. I don't fully understand that part. Look it up. Next, it says, understand the symptoms of mitral stenosis. So here are some symptoms. Patient comes in. It's probably going to be 20 years. It takes about 20 years to develop mitral stenosis symptoms from rheumatic fever. So even though a person, I was 7 when I had this, rheumatic fever, when I had really bad pharyngitis and it, get against my own antibodies or whatever. Anyway, that happened, 20 years ago when I was 7, and now I'm 27, and finally now I'm getting mitral stenosis? Yeah, well, it takes 20 years for it to finally get so much gunk and fibrotic tissue and healing and everything around this thing for it to finally cause mitral stenosis. It says it starts with dyspnea on exertion, but progresses to dyspnea with little activity. So it starts out, boy, I ran. Usually I could run fine before and I wouldn't have a problem. But now when I ran, I was really out of breath, and it'll get worse and worse and worse because where is it going to? It's backing up into the lungs. So then you might get some hemoptysis. That's like coughing up blood. And then, because what's happening here is this is backed up so much. There's so much pressure now on the lungs because it's not getting through here. It's so much pressure on the lungs that blood actually goes. So here's a little alveoli. This has got blood around it. It's trying to get oxygenated. And there's so much pressure in here that the blood goes that way and starts filling up into the little alveoli, and the person coughs up blood. That's kind of scary. Also, they get recurrent pulmonary emboli. So emboli is like a little thrombotic clot of blood, and they keep getting little blood clots in their lungs. Also, pulmonary infections. So, if there's lots of fluid and stuff happening in blood in there, it's kind of an irritated area, and it's more likely to suffer from infections and whatnot. And also, systemic embolization. So, basically, they get little emboli throughout their whole body. Okay, so let's understand the significance of thrombi and emboli in mitral stenosis. The thrombi start in the left atria. So remember, if you've got a lot of pressure in here, you've got a lot of turbulence. And where there's turbulence, it's kind of causing irritation. And if there's irritation and turbulence, it starts to have these kind of clotting factors start to get stimulated. So you're going to start to form emboli. Your blood's going to get swished around so much, it's going to start thinking, oh, we have damage, and it's going to start to try to clot to cover this damage. So it says the thrombi start in the left atria due to increased atrial appendages. And then it says embolization incidence is 10 to 20%. And it says more frequent in patients with atrial fibrillation. So fibrillation, this is where your atria, the signal going from your sinoatrial node down to your AV node, atrioventricular node, and then from your AV node traveling down through those fibers and the Purkinje fibers and everything like that. So this is where the signal from the SA node to the AV node and the AV node down into the atria and all that isn't propagating properly. And so the signal just kind of, your heart doesn't really know when to beat, and just kind of beats too much, and it just sort of doesn't really do anything. And they call it atrial fibrillation because it's just kind of it's not really pumping, it's just sort of twitching and spasming. And it says also understand the physical findings of mitral stenosis, and so with inspection and palpation. So first thing it says, malar flush with pinched or blue faces. So I'm going to really quickly type in here, malar flush. So malar flush, according to this, says that it is the butterfly rash. Oh no, sorry. Malar flush, here it is. Malar flush is a plum red discoloration of the high cheeks, so up here, classically associated with mitral stenosis due to resulting carbon dioxide retention. Okay, so basically a person retains a lot of carbon dioxide, and because they retain all this carbon dioxide, it ends up making their cheeks up here get red. They call this the malar flush. Okay, so mitral stenosis, you think about this because backing up into the lungs aren't getting enough oxygen, it's going to give you a malar flush. So malar flush with pinched or blue faces. So they're not getting enough oxygen, their face might start turning blue. Then it says right ventricular tap along the left sternal border signifies enlarged right ventricle. So apparently, I don't know, maybe they're talking about doing this along the left sternal border, but I'm not really sure exactly what that's talking about, to be quite honest with you. So basically, you get signs of an enlarged right ventricle along the left sternal border, and that, I guess, will help you to diagnose this, whatever. Also, it says a diastolic thrill may be may rarely be present at the apex in the left lateral recumbent position. So left lateral recumbent means they're like laying on their left side and kind of leaning forward a little bit, sort of like this. Okay, except for laying down on a thing. So they're on their left lateral recumbent position, and you take your stethoscope and you put it down here on the apex. All physicians take money, M for mitral, you're listening to the mitral valve, and you put it down there, and during systole you don't hear anything, but during diastole, when this relaxes and blood starts going through here, you hear a thrill, okay? You hear a noise, because the blood's passing from here down to here, because this is relaxed, this is closed, diastole, and you hear that sound down here in the mitral position. So, auscultation. So now, this is says S1 accentuated in early stages. So S1, remember S1 is the AV valves that are closing. Okay, so these valves right here are closing in S1. This one's opening. Systole is occurring. So S1 occurs right at the beginning of systole, or I guess right at the end of diastole, however you want to look at that. The S1 sound, so it's going to be a little bit accentuated. Why is it accentuated? Because there's blood that is was squishing through here during diastole, and then I guess that somehow makes it sound louder. I don't know. It's just, it says now, it says P2, but I think they mean S2. I'm guessing that's a mistake. Let me double check though. Okay, P2 heart sound. So it says the second heart sound. Okay, so the same thing is also two components, A2 and P2. The aortic valve closes earlier than the pulmonic valve. Okay, and they're audibly separated from each other in the second heart sound. This splitting of S2 is only audible during inhalation. Okay, so what it's saying is that when a person's inhaling, normally the aortic valve and the pulmonic valve are going to close at the same time. Normally that's how it happens. But when a person is inhaling, so when they're actually going to happen a little bit separate from each other. You're going to hear A2 first, and then you're going to hear P2, which is the pulmonic valve, happen afterwards. So normally I get exhaling same time, but when they're inhaling, this is happening a little bit later because the pressure in the lungs is a little different. So this happens a little after, it's a little bit delayed, just a little bit delayed. So that's P2. Good to know. Okay, so it says P2 is accentuated with elevated PA pressures. So, PA, that makes sense. Okay, it says the two components of S2 closely split. So remember there's two components of S2. There's S2 and P2, so that's the same thing, closely split. It says opening snap of mitral valve heard best in expiration. So the opening snap of the mitral valve is going to be when the mitral valve first opens. This thing first pops open during diastole. You're going to hear that sound during expiration better. So when they're going, that's going to speed up the amount of blood that's coming from the lungs through here. It's going to pop this open. It's going to be a little bit louder, and you're going to hear it quicker, or louder rather. And then it said OS followed by low-pitched rumble at apex in left lateral recumbent position. And I don't know what OS is, so OS heart sound. And what's coming up here, it says opening snap. Good to know. So opening snap is what an OS means. So opening snap followed by low pitched rumble at the apex or lateral recumbent position. Remember the mitral valve is down here. So you hear that opening snap, and then you're going to hear, so that's it opening up, so it pops open, and then you hear this down here. It's going to be down in the apex, so it's going to be, this is the heart. Apex of the heart is down here. And that's where you listen for the mitral valve, apparently. That's where the best place to hear it. Okay, so now associated lesions. We have severe pulmonary hypertension. So, yeah, it makes sense. Blood's not going through here, backing up into the lungs. You get pulmonary hypertension. Bad deal. pansystolic murmur, which means your whole heart has a murmur associated with it, and then the Graham-Steele murmur. You remember the Graham-Steele murmur was the murmur you hear along that left sternal border, and has to do with basically the blood being backed up into the, from here up. Definition and cause of the Graham-Steele murmur. That's another objective that was mentioned earlier, but just reading again, it says it is an early diastolic murmur on the left border of the sternum due to the dilation, distortion of the pulmonary valve ring. So when you hear Graham-Steele, think of a steel ring, okay? Pulmonary steel ring. Distortion of the pulmonary valve ring that occurs with mitral stenosis due to high pulmonary venous pressures as a consequence of pulmonary hypertension. So the diagnosis of mitral stenosis, you can look on ECG findings, and you're going to find certain things. For one, you're going to find evidence of left atrial enlargement. So what does left atrial enlargement look like on a EKG? So if you remember, maybe you've never learned this, maybe you have an EKG, you look at lead 1. There's all these leads. There's lead 1, 2, 3, there's lead AVR, AVR. You look at these anyway. You look, and you're going to find represented on the EKG, it's going to go kind of like this. Okay, this guy right here, that is representing the contraction of the atria. Okay, now if you have atrial enlargement, usually this is really small. But if you have atrial enlargement, then this is going to be represented as a bigger bump. Now you have to know what normal looks like in order to know what abnormal looks like. So I'd encourage you to go up, look up a normal, and then type in atrial enlargement, and you'll see there the left atrial enlargement abnormality. You also might have atrial fibrillation. Why would atrial fibrillation make sense? This is why it makes sense to me. Remember, this has to work harder to push blood through here. If this works harder, then that means it's going to get bigger. If it gets bigger, then the conduction of the electrical signal passing through the heart is going to be, you have to pass through this big muscular bulbous thing. And if it has to pass through a big muscular bulbous thing, it's going to disrupt the conductivity of the signal being sent through there. And if the conductivity of the signal going through the atrium is disrupted, it's going to react all weird. It's going to fibrillate. Okay, and if it fibrillates, then you're going to have atrial fibrillation. So you might see atrial fibrillation. So what you're going to see on EKGs is your atria just kind of, and then you're going to get a QRS, then it's going to go, maybe a little T wave in there, and then a QR, and it's just going to kind of freak out. Okay, atria just not really doing anything. Okay. It says if there is pulmonary hypertension, then you're going to get a right axis deviation and a right ventricular hypertrophy. And I don't remember what right ventricular hypertrophy looks like, but I believe a right axis, I do know how to do right axis deviation. Oh yeah, that makes sense. Okay, so here's what happens. Here's how you calculate right axis deviation. Okay, so you look at lead, this is how I do it anyways. You got lead 1, lead 2, you probably can't even see this. Let me make sure you can see what I'm looking at here. Okay, can you see what I'm doing over here? Maybe. Got lead 1, lead 2, lead 3, AVR, AVL, and AVF. Okay, so you're going to look at lead 1. Overall, is lead 1 mostly pointing up? And you go to AVF, is it mostly pointing up? 2. Well, if it's mostly pointing up, and this is mostly pointing up, that's normal, okay? However, if you look at these, and you see AVF is pointing down, and you see mostly pointing down, this is mostly pointing up, you see these are pointing away from each other. If they're pointing away from each other, this is a sign of left axis deviation. Left axis deviation means something on the left is big or something on the right is small, okay? So what if you see this? AVF is normal. Maybe it was AVL you're supposed to look at. Darn it, I'm forgetting stuff. better look this up. Might be AVL. If you look at, you might have to look this up. If you look like this at these two, and you find that they're pointing towards each other like this, okay, this is mostly pointing up, this is mostly pointing down, then you have right axis deviation. And if you have right axis deviation, that's a sign of right ventricular hypertrophy, or it's a sign of left heart failure. Okay? You follow that? So you'll find that too in the case of right ventricular hypertrophy. So if this guy got really big before you have failure, because it's trying to push blood through here, push blood through here, push blood through there, then this is really squeezed down. If this is really big, then you're going to find with mitral stenosis possibly right axis deviation, which is a sign of right ventricular hypertrophy. Okay. Next, when you look on the X-ray, so you're looking on your X-ray, got a nice picture of a heart on the X-ray. This is going to be some really nice work here, and the heart kind of goes like this, right? See it on the X-ray, beautiful picture from the X-ray there. And what you're going to find is that the left heart border is going to be a little bit straighter. See, normally it's kind of curved in like this. When I say straighter, it's going to look kind of like this. That's a little bit straighter, kind of like rather than curving this way, it's kind of like a straight edge almost like that. Why is it doing that? Because this right here represents the left atrium. What is the left atrium having to do? It's having to get bigger to push blood through there. So you get left atrial enlargement. Or pulmonary venous hypertension, which shows increased vascularity. And I believe what that is up here you get all this vasculature and stuff. So if you get more vasculature up here, then that means you've got pulmonary venous hypertension, increased vascularity. Or you can see these curly B lines, which are thickening of pulmonary septa second to chronic venous engorgement. So if the veins in your lungs get engorged with blood, then you're going to see these like little lines on the edge like this. And they call these curly lines. And apparently there's curly A lines, there's curly B lines. You can Google it. But if you see the curly B lines, that's evidence of this pulmonary engorgement. And there's pictures of this you can look up online. Just type it in, you'll find it. Okay, so now we've looked on the EKG, we've looked on the X-ray. Let's perform some more tests. Let's do a Doppler on them. Let's do a echocardiography. Okay, so you get out your Doppler machine, put it on their heart, and you're looking at the heart, and you find thickened, restricted mitral leaflets. With classic doming of the leaflets during diastole. Okay, I don't know exactly what this would look like. Look it up online. But apparently, if you know what you're looking at, you see these thickened, restricted mitral leaflets, and the leaflets are domed during diastole. So during diastole, when the blood is traveling from the left atrium down the left ventricle, because this thing's relaxed, because it tightens during systole, remember, so it's relaxed during diastole, these little leaflets here are going to have this sort of domed appearance, a thickened domed appearance. But you have to know what normal is in order to understand what that is. So yeah, that's what you see. So if you do a right and left heart catheter, so remember you can even put a little blood, you can go up through like a femoral artery and all the way up and poke little catheters into people's hearts and read them, and you can actually stick this little thing in there and read the pressures, and you can check the differences in different pressure parts in different people's hearts by sticking these little needle things up in their body and their heart, and you can find a discrepancy between the clinical and the non-invasive findings. And I'm going to sit down while I talk now for a little bit, because my legs are getting tired from standing for so long. And it says this is not usually necessary, but it might be used to aid in surgery decisions. So if you're going to try to decide, well, should we give this person surgery or not, you might use the catheter for that. So next we have something called Ortner's syndrome, O-R-T-N-E-R-S syndrome. And this is a rare cardiovascular syndrome. And it refers to recurrent laryngeal nerve palsy from cardiovascular disease. So Remember earlier I talked about how they have this laryngeal nerve going down here, crossing over, and they call, when this is messed up, they call this Ortner's syndrome. Ortner's. So Ortner's syndrome is when this thing keeps on giving the person palsy. And remember, I think the palsy manifests as them getting a hoarse voice and that sort of thing. So if the person keeps getting nerve palsy from this cardiovascular disease, they call it Ortner's. Okay, next, medical and surgical treatment for mitral stenosis. So if you want to give them some medicine, here's what you can do. You can give them penicillin as prophylaxis, okay? So before you're going to do any work in here, you're going to give penicillin to kill any bacteria that might be in there. At-risk patients with rheumatoid arthritis. So if the person has rheumatic mitral stenosis, then you can give them penicillin, which could kill the streptococcal infection, which might have been given in the first place. So, okay, next thing you want to do is you want to restrict their sodium intake. Why do you want to restrict their sodium intake? Well, this is my best guess, because right here is a lot of pressure. This pressure is built up, and it's making this have to work really hard to push the blood through here. So sodium makes you hold on to water, which increases the amount of fluid in your blood and makes this pressure higher. So you want to restrict their sodium intake to decrease the pressure on there by decreasing the amount of fluid they have. And then you give them small doses of oral diuretics. So there's not a lot of diuretics you can give somebody, furosemide, or you can give them, there's tons of them. So you give them some oral diuretic, help them to go to the bathroom. Diuretics make people pee, and that'll decrease the pressure some more. You decrease the pressure, you're decreasing the amount of work that the left atrium has to do to push the blood through there. Because the more pressure, the more blood, the more pressure, the harder it has to work. Harder it has to work, the more hypertrophic it gets, and the more hypertrophic it gets, the more symptoms you have that can possibly be life-threatening. So if the patient is experiencing atrial fibrillation, what can you do for atrial fibrillation? Well, fibrillation is where this thing's just beating like crazy, and it's beating so fast it's just almost like just jiggling and wiggling around. Well, if you want to slow the heart down, you can give them a beta blocker. Remember, dobutamine kind of gets the heart pumping, contracting harder, whereas a beta blocker, because dobutamine stimulates beta-1 receptors. Beta-1 receptors make the heart kind of pump faster, but beta blockers like carvedilol or labetalol or anything that ends at lol is going to slow the heart down or decrease the contractility. So it's going to make this heart not pump so hard, and if it doesn't pump so hard, then it's going to not get so hypertrophic. And if it doesn't get so hypertrophic, you're not going to have those problems associated with it, and you might actually even stop the atrial fibrillation if you can get it calmed down enough. You might also give the person some non-dihydropyridine calcium channel blockers. So basically, you remember you've got two classes of calcium channel blockers. You've got your dihydropyridine calcium channel blockers, and you have your non-dihydropyridine calcium channel blockers. Let me explain really quickly what these are, how they work. So the dihydropyridine calcium blockers, most of them end in pine. So like I remember some of the names. There's some name, limo to pine and something to pine. Everything ends in pine, like a pine tree. Okay, they block calcium in your vasculature. So in your vasculature, they are going to make the calcium. So calcium is essential for muscle contraction, smooth muscle contraction too. Okay, so for some reason this just targets specifically smooth muscle contraction in your vasculature, and when there's calcium in your smooth muscles, the smooth muscle, the vasculature, your veins or arteries or whatever, clamp down when there's calcium. But if you block the calcium, they can't clamp down, so they open up really big. And if they open up really big, then your blood pressure is going to go down. And if your blood pressure goes down, there's going to be less pressure here. And if there's less pressure here, there's going to be less hypertrophy here. Okay? The reason why there's less pressure here is because instead of all the blood being here, the blood's out in your blood vessels that are all big now. It's not here as much. Okay, so that can help. So what about those were the ones that ended in pine. Those were the specifically dihydropyridine. We're talking about the non-dihydropyridine. So we don't give the person the ones I just talked about. That's not what we're doing. We want to give them non-dihydropyridine. Now these ones act a little bit differently, particularly they're verapamil and digitalis. Okay, or not digitalis, goodness gracious, diltiazem, sorry. Verapamil and diltiazem. So what verapamil does is it acts a lot like a beta blocker in its effects, but essentially it, so it's a little bit more complicated, but you remember you have your sodium channels, you have baseline in your heart, you have all these cells in the sinoatrial node and the AV node and all this like that, Purkinje fibers, and they all have this sort of current that makes them go faster or slower, and this is how it works. You have the resting membrane potential, and slowly sodium leaks in here. When the sodium leaks in here, it finally is going to hit resting membrane potential, and then it's going to fire. All the sodium is going to rush into the cell, and then it's going to stop because all the sodium came in, and potassium is going to start going out. But while potassium is going out, the calcium channels open, and calcium starts to come in, which does that. And then when all the calcium comes in, the potassium keeps going out, and it goes down again, and then the cycle repeats. So if we can mess with these calcium channels here, this is my understanding of it, hopefully I don't misunderstand this. If you can mess with those calcium channels and block them, and you can prolong them, you can lengthen out that period. If I understand it correctly. Maybe I don't understand it correctly, but that's what I understand. Okay. If I'm wrong, please correct me with a comment on this video. Very long video. Okay, next. So you give them non-dihydropyridine like diltiazem or verapamil. So now you just gave them penicillin for the rheumatic heart disease. You restricted their sodium intake. You give them the small doses of oral diuretics like furosemide or torsemide or whatever you say the other one. And then if they have AFib, you gave them a beta blocker and maybe even a non-dihydropyridine like verapamil or diltiazem, and maybe even some digitalis. Digitalis, its effect is going to be on the sodium potassium transporter ATP pump. Okay, it inhibits that, and because it inhibits that, there is less sodium on the inside of the heart for the sodium calcium transporter to use to basically bring the calcium where it needs to go to cause heart contractions. And so less calcium means slower heart contractions. So digitalis will have a similar function, and that slows the ventricular rate, which will help with your AFib or whatever you have. Okay, you can also give the person some warfarin. Now, why would you give them warfarin? Remember earlier I was talking about how all the pressure and sloshing around in here causes little emboli to form. Well, that's bad. Emboli are bad. In fact, one of the symptoms of mitral stenosis is that the person will get little pulmonary emboli and things like that forming. So remember, warfarin blocks some of the clotting factors. It actually prevents the synthesis of clotting factor 2, 7, 9, and 10. It also blocks protein C and protein S. So if you block 2, 7, 9, and 10 from being formed anymore, then the person doesn't have these clotting factors. Warfarin's nice because they can take it at home. They don't have to be in the hospital like they would with unfractioned heparin. And they can take it at home, and it's pretty cheap. The only problem with warfarin is it has a lot of drug interactions because it's metabolized by CYP3A4, and so is everything else in the kitchen sink. So you got to be careful with giving warfarin because of all the drug interactions it can have, particularly some of the ones that also done by CYP3A4, drugs like rifampin or phenytoin, or there's a bunch of them. You can look them up. CYP3A4 is a liver enzyme that breaks down drugs. So anyway, and other things too, like grapefruit juice for some reason, which also affects it. So yeah, so you can give them warfarin. That'll help decrease those other problems. So other things you can do is you can do a mitral valvotomy. I don't know exactly what a mitral valvotomy is. Maybe I should look that up really quick. My guess is that it's stretching out the valve, but let's check. Mitral valvotomy. Okay. This is, balloon mitral valvotomy. Okay, so it's basically, the idea is, it just opens it up. There you go, pretty straightforward. So you can give him one of those. Yep. I'm not reading over anything else we need to cover in this. You can do a catheter. Yep. All right. We understand how that is. So won't go into all the details with that. There's less morbidity and lower peri-procedural mortality rate than surgical valvotomy, so that's good. So you basically put a catheter up there with a balloon. You blow the balloon up, and it just kind of stretches the mitral valve open, and now more blood can get through there. The etiology of mitral regurgitation is the next thing. So we've been talking about mitral stenosis quite a bit, so now let's talk about a little bit about mitral regurgitation. So remember regurgitation, you know what, I'm going to stop there. Actually, this video is already extremely long, and I'll pick up mitral regurgitation on the next one.